Kaptzon. Okay. Thank you. Good afternoon. I would like to talk about CVA after CABG surgery in the area of single cross clamp and arterial revascularization. And I do not have any. Well, let me take you back to 2009 when the syntax trial was published, and they compared PCI patients with CABG patients in terms of outcomes and complications. And one of their conclusions was that CABG patients suffered a higher rate of CVA after surgery. And this is part of the syntax as published. And you can see here that CABG patients had about 2.2% CVA rate after surgery, in contrast to PCI patients, which reported about 0.6%. So it was a large randomized trial, but although the two groups were well balanced in terms of the baseline characteristics and clinical characteristics, there were a few differences that might explain the differences. The first one is that the PCI patients, most of them, received dual antiplatelet therapy for 1 year after the procedure. And this can explain the low rates of CVA, but CABG patients took only aspirin, and this can explain the difference in CVA rate, as I said. And the problem is dual antiplatelet therapy is not an innocent treatment. It comes with a cost in terms of bleeding adverse events, and no one mentioned bleeding events in these patients, so we don't know what the other side of this scale is. The second difference between the two groups was the mean time to procedure. The PCI patient, the average patient waited for about 7 days for PCI, but the wait for CABG surgery was much longer. And when I say much longer, I mean sometimes over 6 months. Why is this important? Again, this is from the syntax trial. There were a few patients that suffered a CVA before the procedure, but they were considered as a peri-procedural CVA. And another interesting finding here is that a large part of the CVAs after surgery were at the late term, over 200 days after surgery. So this is not really an early term complication. Another thing I want to point your attention to is the procedures done in the syntax trial. Only 19% of patients had complete arterial revascularization. And the double internal mammary grafts were used in about 27%. And this is hardly the case today in today's current practical surgical practice. Okay, well, previous studies have shown that intraoperative aortic manipulation can increase the risk for CVA after surgery. And specifically, I'm talking about the side-biting aortic clamp and performing proximal anastomosis. So our study, basically, we aim to establish the fact that if you reduce the aortic manipulation during surgery, you can lower the CVA rates, and in part due to the use of the single aortic clamp or the cross clamp. Well, our study was a retrospective clinical trial, and it included almost 1,200 patients with multivessel coronary artery disease. They all underwent one on-pump cross-clamp isolated CABG, and we defined CVA as a permanent neurological damage after surgery. Most of our patients were men, and the average age was 60. And you can see that 40% of them had diabetes, 67% had hypertension, and other risk factors included PVD and obesity. In terms of the surgery that they got, over 88% got complete arterial revascularization. Again, it's very different from what the syntax trial reported. 100%, all patients had bilateral internal mammary artery grafts, and about 47% of them had an additional one proximal anastomosis. Okay, so these are results. The 30-day mortality was 0.77%, and CVA rate in the early phase, the first 30 days after surgery, was 0.8%. And, well, again, if we go back to 2009, the syntax trial, we went from 2.2% CVA rate after surgery to even higher 2.7% CVA rate in the left main subgroup of the syntax, to the 0.67%. Again, a huge difference for left main patients, as reported in the Noble trial, which was published recently, and they specifically focused on left main patients. And this is, well, this is a lot closer to our results of 0.8%. So you can say that we're actually more similar to the PCI group in the syntax trial than the reported, of the original cabbage group. So again, minimizing aortic manipulation during the surgery can reduce the stroke rate substantially, and it's comparable to the results of the PCI group in the syntax trial, and again, without compromising the postoperative outcome. And by reducing aortic manipulation, I mean the use of a single aortic cross clamp and avoiding the side binding clamp, using in situ bilateral internal mammary grafts, and minimizing the number of proximal anastomosis. And if performing proximal anastomosis, we generally use the cardioplegia punch hole, again, minimizing the aortic manipulation. Thank you.
Any questions? Yes. First of all, very, very nice presentation, very, very nice results. Another option, one option is to do what you are doing. The other option is to use epi-aortic ultrasound and then make the decision, sometimes avoid the cross-clamp whatsoever. What is your, do you use epi-aortic ultrasound?
No, we don't have any experience in our work.
I think it confirms what I believe most people are doing already with modern cardioplegia. Of course, you haven't got a choice, but otherwise, with modern cardioplegia, I believe most people are already avoiding side-binding clamps anyway.
Well, our aim was basically to show that in the current surgical practice, we are better than the rates reported, and it's true. We actually did reduce the severe rates. This was just a way of showing it.
Do you think the retrospective nature, how you looked at the data, and whatever bias may be there in terms of how you define a stroke, you know, how sensitive the practitioners were to picking up strokes and doing imaging? Do you think that could play a role in the difference you see versus what you saw in the prospective syntax trial?
Well, it definitely can play a role because we established a trial on an official diagnosis of a CVA, and it is possible that we're underdiagnosed, or maybe patients lost in follow-up during 10 years of the trial. We don't have enough prospective data to actually answer that question.
Thank you.